Hello and welcome everyone to today's presentation, Demystifying Autism Spectrum Disorder in the Clinical Setting. My name is Dr. April Phillips, and I am currently the Clinical Director of the Psychiatric Mental Health Nurse Practitioner Program here at Frontier. It is truly my pleasure to introduce our guest speaker today. His name is Dr. Kevin Scalf. He is a board-certified psychiatric mental health nurse practitioner with over 11 years of experience. He has worked with patients across the lifespan, but has spent much of his career working with children and adolescents. He has particular expertise in the area of neurodevelopmental disorders, ADHD, intellectual disability, and autism spectrum disorder. Dr. Scalf graduated from Eastern Kentucky University, where he earned his associate degree in nursing. He went on to receive his bachelor's of science degree in nursing and a Master's of Science in Nursing. He also has a postmaster's certificate in child and adolescent psychiatry. We are pleased to say that he has earned his doctorate of nursing practice from Frontier Nursing University. He is not only one of our esteemed alumni, but he is also one of our clinical faculty and serves as leadership in the clinical bound department. Dr. Scalf is currently working in his own private practice and brings a great deal of expertise. In the past, he has worked with the Office of the Inspector General as a nurse consultant. And in addition to his teaching, his passion and mission is to provide individualized and effective care to individuals who struggle with psychiatric and mental health problems across the lifespan. I would like to add that Dr. Scalf has devoted much of his career to working with underserved populations in Kentucky and lives on to really lead the mission of Frontier Nursing University to really provide those services to those in need. Thank you, Dr. Scalf.
Thank you, Dr. Phillips, for that warm introduction. Good evening, everyone. Thank you so much for joining us this evening. My name is Dr. Kevin Scalf, and I will be hosting a conversation to you this evening about autism spectrum disorder, specifically demystifying autism spectrum disorder in the clinical setting. How do we recognize it, and how do we know when intervention is needed? So thank you so much for coming out and being part of this presentation. This is just a slide that talks about the CEU benefits as a result of participating in this conference. In order to obtain the 1.5 hours for this activity, you must complete the entire video in course and complete a post-evaluation with a score of at least 70%. I have no relevant financial relationships or any disclosures to mention, and this course will be running up until November the 15th of 2023. Before we get started this evening, I would like to take a few moments and talk about our objectives. So by the end of this session, I would like for us to have a discussion and talk more about and have a more informed discussion about the hypothesized etiology related to autism spectrum disorder. I would also like for us to identify the key non-pharmacologic and pharmacologic treatment strategies related to autism spectrum disorder, and also, very importantly, identify the caregiver's role in the treatment of autism spectrum disorder. So I'd like to start off by having a brief discussion about the evolution of autism over the years, where it has come from, where we are currently, and also where we need to go in the future. The term autism has been around for a while. The term was actually coined in 1911 by a German psychiatrist named Eugen Bleuler. He used this term autism to describe a symptom in children that resembled some of the most severe cases of schizophrenia. So for some time, autism was considered to be a type of childhood schizophrenia. Psychiatrists saw children that experienced problems with language and social interaction and just assumed that these children would grow up to be psychotic, delusional, and ultimately be diagnosed with full-blown schizophrenia. As the years went by, however, the medical world started to see a very distinct difference in some of the patient cases. They were really not sure what this meant, but they knew that a lot of the children that exhibited these types of symptoms did not go on to develop schizophrenia. And this was somewhat confusing, uh, but it really did lead to the realization that there was a distinct category of children that seemed to have just a separate issue, a separate challenge with the area of language formation and social interaction. So this kind of sparked a debate within the medical community per se. And as the years went by, the hypothesized etiology behind autism went on to include a variety of theories. So some of the theories around in those early times postulated that the etiology of autism was cold parenting. In this case, it was thought that the mother was cold and non-nurturing, and so these mothers became known as refrigerator mothers. Other theories out there involved what is known as infantile wishes. In this theory, the child was unsatisfied with their reality, so they developed alternative realities. And so as more research was generated upon this topic, the evolution of autism and the description of what it is and what we think it is kind of evolved over the years. And it really started to take on a broader experience and understanding. It was really highlighted also during this period of time that autism and the characteristics of autism spectrum disorder were not the same for everyone. This added to the complexity of the diagnosis, and at first was very confusing to people who were studying this. It was really not until 1980 that autism started to be considered a neurodevelopmental disorder. The DSM-3 described it as a pervasive developmental disorder. And if we fast forward to the current day, the DSM-5 refers to autism as autism spectrum disorder, acknowledging the fact that symptoms vary from individual to individual, and that there is also a continuum of severity. We now know that the risk factors for autism spectrum disorder are really multifactorial and include genetic and environmental factors. And we also recognize that autism disorder requires a multidisciplinary approach. So really, if you think about over the years, we've came a long way. There's a lot that we've learned. There's still a lot that we need to learn, but we have made progress, I think, since those early days with Dr. Bluter. The concept of the refrigerator mother actually was around until the 1960s, 1970s, if you can really kind of believe that. With the DSM-3, we started to see autism be recognized as a separate disorder. The diagnostic criteria, again, went through some revisions in 1987. And in 2000, autism was really starting to be viewed as a spectrum disorder, although we still had those subdiagnoses in the DSM at the time that included things like Asperger's and pervasive developmental delay. When the DSM-5 came out around 2013, the name was officially changed to Autism Spectrum Disorder, and terminology such as Asperger's and pervasive developmental delay were really no longer used. And so now, in our present day, with autism spectrum disorder, we recognize that the disorder runs a spectrum. It has an individualized characteristic presentation and includes all of those previous subdiagnostic categories, like, for instance, Asperger's. So let's look at what the DSM-5 talks about when we think about autism spectrum disorder. The DSM-5 outlines some of the characteristics that a person displays with this disorder. And some of these are mentioned here on the slide. Number one, persistent deficits in social communication and interactions. Restrictive and repetitive patterns of behavior, interest, or activities. And the symptoms must be present in the early developmental period, according to the DSM-5. And the symptoms cause significant impairment in functioning But also we highlight the fact that there are varying levels of severity, and this is indeed a continuum of severity. At this point, I would like to pause and just kind of highlight the fact that the DSM-5 uses terminology such as symptoms and treatment. I think this is progressing, and it continues to evolve within our community. Because when we focus on disorders, sometimes we really put an emphasis on the neurotypical brain. And I think now that we're beginning to understand more about autism spectrum disorder, we are really placing a lot of value on the individuality of the person and helping the person to accept their condition, and also to realize that they can lead a meaningful and happy life. And so I think sometimes the terminology symptoms and treatment really set forth a negative connotation that really should not be there, because we know that each individual person is unique and they bring individual talents and are great assets to our community. So let's first look at the social communication and interaction concept. What does that really mean? Well, limited back and forth exchange is one. Limited nonverbal communication is another, and also limited ability to build and keep friend relationships. So let's look at the limited back and forth exchange. Keep in mind that this is a continuum. And so on the mild end of this concept of limited back and forth exchange, someone may appear as socially awkward. They may have some difficulty in keeping a conversation going with other people, for instance. While at the severe end, the individual may not have the ability to communicate at all. So we do see that continuum still run the gamut when we look at these different concepts and the diagnostic criteria that make up the disorder. We look at limited nonverbal communication. We all know that most of our communication is nonverbal, but on the mild end, the individual may have some difficulty in exhibiting nonverbal body language that's really congruent to what they are speaking or what they are talking about. And so, in other words, this person's verbal and nonverbal communication may appear to be incongruent with each other. At the severe end, the individual may have no facial expressions or severely limited facial expressions, and they may not display any type of nonverbal communication patterns at all. So again, we see the continuum of severity. And then also we talk about the limited ability to build and also keep relationships. On the mild end here, we may have difficulty in adjusting our behavior to various social contexts. Again, we may appear as kind of socially awkward. And because of this, interpersonal relationships could be sometimes hard to initiate and also hard to maintain. While at the severe end, the individual may not have a desire to have friends at all, or maybe they have a very limited desire to make friends and keep friends and network within their society. So when we look at these core diagnostic criterion that's associated with autism spectrum disorder, we do see that continuum of severity. And it's really important for us to understand and remember that there's no case that looks exactly the same. Everyone's presentation is unique. When we look at restrictive and repetitive patterns of behavior, what are we talking about? So we look at repeating body movements. We look at inflexible routines or behavior patterns. And we also look at altered sensory perceptual responses. So what does all that really mean? So when we look at repeating body movements, you may see repetitive or stereotypical type of behavior. Examples of this could include such things as repeated rocking back and forth by the individual, hand flapping, pacing, or more on the severe level, it could consist of head banging, especially when someone is agitated and frustrated. We look at inflexible routines and behavior patterns. So what does that mean? We could see someone kind of abnormally fixate on the need for order in their environment. For example, We may see a child, such as in this picture right here. The child really hyperfixates on lining things up in a straight line. And maybe the child has difficulty engaging in the actual play of the game or activity with other children because they spend more time talking about the rules of the game instead of really just playing the game. So there's this insistence on sameness. Small changes in schedule can be very difficult things to experience and manage for this individual. Also, this individual could have some rigidly fixated interests. As I think back and I think about the children that I have seen in clinic with autism spectrum disorder, I could think of an example such as a strong attachment or preoccupation to objects such as desk fans, vacuum cleaners, and that sort of thing. They just have an abnormally heightened fixation on certain objects within their environment. And these objects appear to kind of act as a safety blanket to these individuals at times. Then we look at altered sensory and perceptual responses. So what does that entail? Here, there could be a hypo or a hyper reactivity to sensory input. Some examples that I think about with this could be, let's say, an apparent indifference to pain or temperature. Some patients with autism spectrum disorder have a very high pain tolerance, and things that would be very painful to other individuals are only mildly or not very painful at all. So we do see this hyporeactivity sometimes to pain and temperature. But we also see hypersensitivity sometimes, even in these same individuals. This could be seen, let's say, as a hypersensitivity to sound, certain textures, certain smells. Sometimes the individual with autism spectrum disorder experiences some of this hyperreactivity, and they find just even the slightest scent of something just very intolerable. So we see a combination sometimes of some hyporeactivity, but also some hyperreactivity as well. So when you look at the entire presentation and the constellation of symptoms, we do see within this realm the repeating body movements. We see the inflexibility with routines and the altered sensory and perceptual responses. This is just kind of a table that illustrates the point that this is a continuum. There's no same presentation for any one. Everybody's presentation is different. And here we see the severity level. And this slide talks about mild, moderate, and severe. In the DSM-5 uses the criteria level 1, level 2, and level 3. But when you look at mild, and you look at the mild presentation, the individual may require some support, such as difficulty initiating social interactions. And so they may need some intervention in that area. But overall, the symptom severity is pretty mild. Then we have the moderate level of severity, and this is kind of a heightened level of challenge that the person experiences. Again, we see limited social interactions, we see narrowed special interest, and maybe some frequent repetitive behavior patterns. And then level 3, which would be severe, requiring very substantial support. This is on the severe end of the spectrum. And we see severely defective verbal as well as nonverbal communication skills. Sometimes the individual may not be able to speak at all, and they have great difficulty in changing their actions, changing their focus, and also adapting to different types of environments. It's really important for us to remember, I think, that small changes in routine, small changes in one's environment, those are big things to some people who have autism spectrum disorder. So we always need to remember that sometimes little things to us can be big things to other people. And always remember as well that there's no same presentation to this disorder for anyone. Everyone's presentation is unique. So let's talk about the hypothesized etiology of what we're talking about. We've made a lot of progress, like I said at the beginning, but we still have a long way to go. But here's what we do know. It's a complex disorder. There's no single known cause. And also there are genetic as well as environmental factors that play into the etiology and the reason behind why we see autism spectrum disorder. Let's first talk about some genetic factors. So number one, because there is a genetic inheritability associated with this disorder, we know that a family member with a diagnosis increases the chances of someone else in the family developing autism spectrum disorder. Also, boys are 4 times more likely to develop this than girls. Fragile X syndrome is also a genetic condition that we see oftentimes positively correlated with autism spectrum disorder. And if you think back about Fragile X syndrome, Fragile X is a genetic disorder, of course, and it occurs when a single gene on the X chromosome kind of shuts down. And this particular gene makes a protein that is needed for normal brain development. But what happens with Fragile X syndrome is this gene does not work properly, so therefore the protein is not made. And sometimes the brain does not develop in the trajectory that it really should. And sometimes we see that as a segue into the later development of autism spectrum disorder. Also, Rett syndrome. Rett syndrome is a rare genetic and neurodevelopmental disorder. And basically, it also affects the way that the brain develops, but it causes really a progressive loss of motor skills and speech ability. And so the individual ends up comprehending more than what they can actually communicate. This is a rare genetic neurodevelopmental disorder, but it does happen. And it has been positively correlated with autism spectrum disorder. It's interesting also to kind of point out with Rett's disorder that it primarily affects girls. It can affect males, but primarily we see this in the female population. So when you think about genetic mutations and the genetic aspect of autism spectrum disorder, it's just really important for us to remember that there are hundreds of genes that could contribute to the development of autism spectrum disorder. And that's one reason why that we see different symptom presentations in the patients that we serve. That's another reason why we see it with varying levels of severity, because there are so many gene considerations to think about, so many opportunities for something to happen within the genome that would predispose us for autism spectrum disorder. I heard a talk one time on autism spectrum disorder that really tried to highlight this and illustrate this point. And I thought that it was a really good illustration. And I heard someone talk about encyclopedias. I'm kind of probably dating my age back a few years, but I remember when we had entire sets and volumes of an encyclopedia. Some of you may know what I'm talking about. But if you could view that entire set of encyclopedias as the DNA genetic sequencing, okay, all of the volumes are in place, all of the pages are in place within each volume, everything is as it should be. We can pick up a volume of that encyclopedia and start reading it without any issues. But let's say that we have someone with level 1 or mild autism characteristics. So in order to kind of look at that on a genetic level, you can imagine maybe having a full set of encyclopedias. Remember, those are the genes. So we have a full set of encyclopedias and we pull out a volume and we start reading it. But as we start reading that volume, we notice that there's maybe a sentence or two that has a few words missing. We can still kind of take inference and know what the content is about, but it does require some extra effort on our part to really understand what we're reading. And so that could maybe illustrate what happens on the genetic front when we develop mild symptoms of autism spectrum disorder. There's a small mild symptom presentation that we see based on those genetic inheritabilities. If you think about someone who may have level 2 or moderate characteristics of autism, think about pulling out that same encyclopedia book and you turn it to a particular chapter and there's a whole paragraph missing. And you're trying to read the material for understanding, but it's a little more difficult because there's an entire paragraph, or maybe there's entire paragraphs that are missing within that volume. And so we struggle maybe just a little bit more. And then if you think about things on more of the severe end of the spectrum, think about that set of encyclopedias, that genomic sequencing, and there's one entire book that's missing. And so that could illustrate some ways in which individuals just really experience different levels of severity with autism spectrum disorder. And so our knowledge base has come really a long way since 1911 with Dr. Bluler, but we sure do have a lot more to learn about autism spectrum disorder. But we do know that it is very high with genetic considerations. Then let's talk about environmental factors. Okay, those play a really important part as well with autism spectrum disorder. What do we know? We know that children born to older parents have an increased risk and are more positively correlated to experience and develop autism spectrum disorder. Low birth weight, we see that as well. One interesting thing is the maternal use of valproate, also known as Depakote. That's been positively correlated with the development of autism spectrum disorder. And then we find new things out each and every day related to this. Some of the things that come to my mind when we think about these other potential factors that we are investigating. Number one is maternal infection, viral infection, malnutrition, perinatal hypoxia, exposure to heavy metals during pregnancy, and also low maternal folate and vitamin D levels are known to be positively correlated to autism spectrum disorder. And if you think about that, that kind of makes sense, I guess, because if you think about the function of folate plays a very important part in making up DNA, and it has a very strong part to play with our genetic sequencing. Also, vitamin D is very important for the development of our central nervous system. And so it really does kind of make sense when you think about the fact that low maternal levels of vitamin D and folate a lot of the time are correlated with autism spectrum disorder. So this is an opportunity for us in practice to identify these things and really work to prevent some of these problems and complications. As nurse practitioners, that's really what we're all about, is health promotion and disease prevention. We want to maximize our level of wellness and try to mitigate some of the risk factors that could cause some issues later on down the road. So let's look at the facts. Let's look at some data. Depending on which source that you read, currently about 1 in 59 children are diagnosed with autism spectrum disorder. I have read one reference that actually cited 1 in 44 children have autism spectrum disorder. We know that there's a genetic predisposition for sure. This disorder affects all racial, ethnic, and socioeconomic groups as well. And it's 4 times more common in boys. This next bullet point is very interesting. 83% of individuals also have a comorbid diagnosis. So there's more going on sometimes than just autism spectrum disorder. And we also know that autism spectrum disorder costs an estimated $11.5 billion to $60.9 billion annually in our healthcare system. Just some facts to kind of think about as we go through. So what kind of comorbid conditions do we usually see with autism spectrum disorder? So let's talk about that. Here are some common ones, but this list is not entirely exhaustive. But some of the things that we do see comorbidly with autism spectrum disorder would include intellectual disability, speech and language delays, attention deficit hyperactivity disorder, anxiety disorders, depressive disorders, also tics and Tourette's syndrome, as well as schizophrenia. So we really need to keep in mind as we are providing care to patients with autism spectrum disorder that there is a pretty significant likelihood that there's more going on, and there's more that's going to influence the clinical presentation than just the autism spectrum disorder alone. And so that's something I think that we need to kind of keep an open mind about as we start to look at clinical presentations and as we start to plan treatment. So this is a good segue into talking about clinical presentations and what does that look like? We've already kind of discussed and we've kind of established the fact that autism spectrum disorder does include and have these constellations of signs and symptoms that we've talked about. But at the same time, we have to highlight and emphasize the fact that each presentation is different. Each presentation varies in what we see. It also varies in the severity level that we see. What we do know is that the characteristics and symptoms are usually evident by age 2 years. Sometimes maybe a little bit before that, but by 2 years, we're starting to see some things. And this is really something that we can pick up on working in the clinic, maybe as the primary care provider that's doing well child checks, looking at some of the things that really kind of concern us at this developmental age, because the symptoms usually are evident by around 2. We do know that symptoms are usually lifelong, but also having said that, individuals with autism spectrum disorder, they offer a very unique a contribution to the world. I tell patients all of the time that you're pretty special because there's only one of you in this entire universe, and that really makes you kind of special. People who are diagnosed with autism spectrum disorder really need to hear that. And so even though we know that symptoms are chronic and usually they are lifelong, it is possible to rise above some of these symptoms and to develop coping strategies and enhance resiliency. And people with autism spectrum disorder, just really, we need to work with them to help them understand that life can be productive. They can live a very good life. And just because their life is different than someone else's life, that's okay, because we're all different. And that just really enriches our experience from day to day. And also symptoms have varying levels of severity. Like we said, there's level 1, level 2, and level 3, or you could look at it as mild, moderate, and severe. What are some potential complications that we see as the result of autism spectrum disorder? As the child begins to age and we start to socialize more with friends, we start to get into those school age years. What kind of things do we look at? Well, the first thing on here we see are problems with school and successful learning. One of the things that we have to keep in mind is that individuals who have autism spectrum disorder, they just learn different than other people do. And that's not necessarily a negative thing. We're just all different, and we may see the world from a different perspective, a different lens. We learn differently. So it's really important for us to work closely with the school system, with the parents, with the caregivers, to make sure that the individual has things put in place, that they have resources that they need, and that we give them the tools that they need to be successful in their educational learning. We can also sometimes see employment problems later on in life with some individuals who have autism spectrum disorder. Again, I think part of the issue that we see now sometimes is the fact that we place such a big emphasis upon the neurotypical brain. We think sometimes that everyone's brain should just work the same. We should see things the same way as everyone else does, but that's just not reality, is it? We all see things differently. We all have a different lived experience. And so we learn differently. And sometimes I think this emphasis on having a neurotypical brain or that typical expectation can sometimes cause problems when we start to get into the employment phase of our life. Sometimes it's during this period of time that individuals with autism spectrum disorder experience things like pathological anxiety, maybe depression, and we start to see some of that stuff kind of come out more during some of these years. Also, limited ability to live independently. This would probably be more on the severe end of the spectrum. Um, and maybe the individual needs significant resources. Maybe they require significant assistance with certain ADL functions and certain ADL tasks. And so that's something that we see sometimes that causes a lot of distress. We also cannot forget to think about the family. When we sit down with a patient, we also have to remember the family system. And one part of a system affects another part of a system. And so when you have a family member or someone in your family that has been diagnosed with autism spectrum disorder, and maybe they're even more at the severe end of the spectrum and they require significant assistance, well, sometimes that causes a lot of stress within that family system, and we start to see things come out. We need to remember the family as we sit down and we interact with and we plan treatment for our patients. Also, victimization and bullying are complications that we see from time to time with autism spectrum disorder. When I sit down or when I work with a child or an adolescent, I always want to ask about bullying behaviors. I want to know how school is going. What do you like the best about school? What do you hate the worst about school? And sometimes we have to get very concrete in how we ask these questions. And so sometimes I may ask the question to a patient, has there ever been a time when you felt like someone went out of their way to be mean to you or to say hurtful or hateful things to you? Because if we say something about bullying, sometimes people don't understand that terminology. So we have to really remember to meet the patient where they're at and use terms that the patient can actually understand and be involved in a conversation about. So these are just a few complications that we may see with autism spectrum disorder. Again, this is not exhaustive at all, but it's some of the more common ones that I have seen over the years in practice. So let's talk about treatment. And when I use that term treatment, I don't mean that in a negative context at all. I think each and every individual has an opportunity to achieve their optimal level of wellness. And just because someone with autism spectrum disorder thinks about things differently, maybe their brain functions in a different way or processes information in a different way, that's not necessarily a negative thing, right? So we always want to be able to empower patients with autism spectrum disorder. And I guess if I could use a substitute word here instead of treatment, I would use maybe a phrase that deals with ways to empower individuals who have autism spectrum disorder. And so when you look at this, there are a few things that we really need to take a look at and talk about. The first one is early diagnosis and early intervention. It's the same as with anything else. The earlier that we identify something, the earlier that we begin to employ interventions, the better the prognosis. And so really screening at an early age, like I said, at these well child checks, even around 2 years of age, if we start to see things as a primary care provider that concern us, we need to ask ourselves the question, do I need to set in place maybe a referral for further investigation? We really want to be hyper-focused on anything that would make us worry about the development of this later on in life. We'll also talk about some pharmacological and non-pharmacological approaches to managing autism spectrum disorder. There's no one drug that's approved to treat autism spectrum disorder, but basically we treat symptomatically. And we'll get into that more in just a few moments. Progressive adaptation I have listed here, and you may be wondering kind of what that is or what does that entail. And this doesn't only pertain to the individual's adaptation to their environment, but I also think that society as a general population of people, we need to adapt ourselves to the thinking that not everyone thinks like we do. Not everyone processes information like we do. And so we need to adapt, I think, our own thinking into that lens of reality. And we also need to think about caregiver and family support. Families, caregivers are oftentimes stressed. Oftentimes they have very limited knowledge about what autism spectrum disorder even is. And they find themselves sometimes just grasping at straws. You kind of compound that sometimes with the scarcity of resources in certain geographic locations, and it really makes for a very stressful experience for the family and the caregivers. So we really need to take some consideration. We need to think about this and also ask the caregivers, ask the families, how are you doing? And provide education and support. Because if we can help the family and if we can help the caregiver feel more safe, more secure in their environment, that's positively going to affect the treatment and the management of our patient. So don't forget about the caregiver and the family support. It's very important. This is a slide that just talks about some of the screening tools that you may see used when you refer someone for testing. When you look at neuropsych testing and psychological testing, there are a host of different screening tools that you may see used by trained professionals. It's just really important to remember that there are a lot of screening tools out there, and the diagnosis should not come from just one screening tool. The screening tool is a valuable piece of information for sure. But at the end of the day, we have to really also utilize clinical judgment, and we have to look at things across a variety of environments and across multiple contexts. So although we look at screening tools and although they are very important and they give us a lot of good information, the diagnosis should not come from only one screening tool. So let's talk about pharmacology. Like I said earlier, there's no single medication that's proven to treat autism spectrum disorder. But what we do is we use pharmacology as a useful adjunct to environmental and behavioral interventions. So they work in concert with each other, the pharmacological and the non-pharmacological. Most of the time, we use pharmacological treatment to help manage associated symptoms. And we're going to get into what some of those symptoms might be in just a few slides. But basically, when symptoms are interfering with quality of life, maybe they're interfering with safety, we use and employ medications to help manage those target symptoms. We always have to weigh risk versus benefit when we're using any type of medication. What's the benefit? What's the risk, the benefit, and alternatives? Because we have to provide informed consent to the medications that we use in the treatment of autism spectrum disorder. And just generally speaking, in child adolescent psychiatry, honestly, there are probably very few medications that are FDA approved for a certain thing. So what does that mean? We end up using off-label medications a lot with children and adolescents. And when we do that, we really need to make sure that the patient, to the level that they can understand, and also the family, the caregivers, they understand that we're using things off-label, and here are the risks and here are the benefits. And we have to ask ourselves the question, do the benefits outweigh the risks of the particular medication that we're going to be using? So we want to make sure that we always gather a good informed consent. So when we talk about pharmacology and we talk about pharmacological agents, there's a few that we're going to cover in this general presentation. One would be the psychostimulants. Number two would be antipsychotic medication, specifically the atypical antipsychotic drugs. We also use antidepressants from time to time, as well as alpha-2 adrenergic receptor agonists. And so these are probably the four most commonly used, commonly seen classifications of medications that we see when we're looking at treating some of the symptoms associated with autism spectrum disorder. So let's first talk about psychostimulants. So, you may be asking yourself the question, why would someone who has autism spectrum disorder require or benefit from a psychostimulant, right? Well, if you remember back a few slides, we also said that there are certain comorbid conditions that are present a significant amount of time. And one of those comorbid conditions that we see is ADHD. And so sometimes if we can use psychostimulants to help improve, stabilize, just make some of those target symptoms better, we see that the overall clinical picture improves. And so the reason why we use psychostimulants is to help improve, stabilize, and decrease things like pathological hyperactivity, pathological inattention, pathological impulsivity. Psychostimulants have been known to really help with some of those target symptoms in individuals who have also got a comorbid diagnosis of ADHD. And sometimes we really have to educate the parent and the caregivers about why that we're giving a stimulant to help calm someone down. Oftentimes I've sat down with parents and caregivers and I've talked about stimulants and what I hope to accomplish with this stimulant. And at first, their initial reaction is one of kind of fear because the individual is already hyperactive. They're already impulsive. They already have a very difficult time sustaining attention. And so we really have to educate ourselves sometimes about the fact of why that these medications do what they do. But along with medications, there's always potential side effects. There's always a pro, there's always a con, right? And so when we look at potential side effects of psychostimulants, some of the side effects that I see include decreased appetite. Sometimes the stimulants just kind of decrease and they knock out the appetite. So we have to really look at that, and we have to monitor their appetite, look at their weight, look at their height. Are they still meeting those developmental milestones and trajectories? So we have to look at the appetite. Also, tics. Sometimes psychostimulants can cause or exacerbate tics. So that's something that we need to educate the patient and the caregivers and the family about. In some individuals, even though psychostimulants may produce a calming effect and decrease irritability in some people, there are certain people that psychostimulants add to the irritability. So we oftentimes have to talk about that and have a little discussion about that. Nothing should get worse. That's something that I tell my patients when I start medications. Nothing should get worse. There's certain times, certain medications that we use that maybe take a little while for us to start seeing some therapeutic effect, but nothing should get worse. And so if we can educate the parents, the caregivers, and also the patient about this on the front end of it, if this starts to come up, it's less scary to the family, to the caregiver, and even to the patient, because we've had a discussion about it. But we can see that irritability manifest as a side effect. Also, sometimes stimulants can cause increased blood pressure. Sometimes it can cause increased heart rate, that kind of thing. So we have to keep that in mind and monitor that from time to time while we're on that therapy. So you will see psychostimulants used with patients who have autism spectrum disorder, and oftentimes we see those used when the person has a comorbid ADHD presentation. Because what we honestly want to do is we want to help calm the individual. We want to help them to be more present in the here and now, to be able to tolerate more distress and frustration, and just to decrease that impulsivity. We also see antipsychotics being used sometimes. We oftentimes see the atypical antipsychotics especially. And so you may ask yourself, why would we use antipsychotics on an individual that's not psychotic, especially maybe a child or an adolescent? Well, in psychiatry, we use these medications a lot for a lot of different reasons. And so when you look at antipsychotics in general and talking about the atypical class of antipsychotics, they really do help target symptoms such as irritability, maybe some disruptive or aggressive behaviors that the person is displaying, maybe some stereotypical movements that are causing severe distress in someone's life. You may see antipsychotics being used in those circumstances, um, especially if these behaviors are starting to interfere with or potentially jeopardize safety. In psychiatry and mental health, we're all about safety. We have to establish safety first and foremost. And let's say, for instance, if we have an individual who has a very low frustration tolerance, they really can't maybe communicate what's bothering them like other people can. And so that adds to their frustration. And as a result of that, they may start hitting their head against a wall. Maybe they start head banging. We have to intervene in that kind of a situation because that is potentially jeopardizing someone's safety. And so you'll see these medications used in those instances where the benefits do outweigh the risks. When it comes to antipsychotics, yes, there are risks involved and there are potential side effects that we see from time to time. A few of those side effects I have listed here, such as weight gain, that's more common sometimes with the atypical, the second generation antipsychotics. Sedation, dizziness, that's always a possibility. And also tremors. I think we've all heard of extrapyramidal symptoms, EPS. We can see those as well as side effects in individuals that we use these drugs with. Even though the tremors may actually come more from first generation antipsychotics, they still have a potential to cause distress in some people. We also see antidepressants being used a lot. And you may ask yourself, why do they use antidepressants in people who have autism spectrum disorder? Well, sometimes individuals have feelings of depression to the point that it's pathological. Sometimes we have anxiety to the point that it's pathological. And also, you may see antidepressants being used when someone has repetitive or maladaptive type behaviors as well. And if you look at that third bullet point, repetitive maladaptive behaviors, you may ask yourself, why would an antidepressant help with repetitive or maladaptive behaviors, right? Well, if you think about that, that kind of makes sense because in individuals who can't communicate effectively, maybe their fears, what's causing them to be anxious, they can't communicate that very well. So what happens is you may see an increase in that stereotypical type behavior. Remember when we talked about the rocking back and forth? We may start to see that when an individual becomes anxious. And we all know that antidepressants can be first-line treatment for anxiety disorders. And so you'll see antidepressants being used with patients who have autism spectrum disorder because of depression sometimes and sadness, but also because of anxiety. But we all know as well, there are potential side effects associated with antidepressant use. In fact, we have black box warnings out there that sometimes these medications can increase suicidality in children, adolescents, and young adults. So that's something that we can't take lightly. Also, sometimes we see antidepressants result in worsening of mood, maybe activation of mood, or maybe they're excessively sedating. That's something that we have to carefully weigh risk versus benefit with. One of the big reasons why people stop antidepressant therapy is weight gain. And also nausea, vomiting, and diarrhea, some of those GI symptoms. And so we have to do some really good education with patients when we use these medications, again, to kind of get ahead of things in case they do happen, and so that the patient's not caught off guard and they become distressed when they see some of this stuff happen. And then we have the alpha-2 adrenergic receptor agonist. So what is that about? When I think about this class of medication, there's two medications that really kind of stand out and come to my mind. One would be guanfacine, branded 10X or Intuniv. And then I think about clonidine. Those are two good examples of medications that fit within this class. And so why would we use these medications in a patient who has been diagnosed with autism spectrum disorder? Well, again, it's similar to what we've seen with the stimulants. They decrease irritability. They decrease that aggressive behavior. The hyperactivity and impulsivity, these medications tend to stabilize. They also have anti-anxiety properties, and they can help promote sleep and kind of mitigate sleep disturbance. Something that I always tell students is the fact that sleep is very important. When we don't sleep, everything else gets worse. And so we have to look at sleep patterns and how are things going within the realm of sleep. And so these medications can actually help with that. And they really do help a great deal with these types of symptoms in the patient who also has comorbid ADHD. But again, we see potential side effects. There's always a risk, there's always a benefit. Some potential side effects that we may see with these medications include sedation, fatigue, maybe some hypotension because of the nature of how that these medications act. So that's just something to kind of keep in mind. But when you're thinking about pharmacological management, it's just really important to remember that we treat symptoms associated with either the comorbid diagnosis or with the autism spectrum disorder itself. And that we must carefully weigh the risks versus the benefit and do good informed consent. And ask ourselves the question, do the benefits outweigh the risks? So now let's move on to non-pharmacological management of autism spectrum disorder. And the first slide that I have here is related to applied behavioral analysis, ABA therapy. I would be willing to wager that almost everyone has heard of this, if not experienced it or have worked closely with someone who has underwent ABA therapy. ABA therapy has really been around for a while. I think it stems back into the 1960s, 1970s. It's been endorsed by the American Academy of Pediatrics, and it's been proven to be effective in some cases with autism spectrum disorder, but that does not mean it's without a downside. And there are schools of controversy out there related to ABA therapy. Some schools of thought kind of postulate that ABA therapy is too intense for an individual because when you think about ABA therapy, this could be up to 40 hours a week of therapy for an individual. It's very aggressive sometimes. Another argument that some people put forth with ABA therapy is that it kind of forces the individual to adapt to the way other people view the world because they don't have that neurotypical brain. Sometimes the argument is kind of raised that ABA therapy attempts to make everyone think like a neurotypical brain would think. And so that's an area of discussion and controversy that we do see with ABA therapy. But despite that, you will see a lot of ABA therapy in use and in practice. There are different types of ABA therapy out there, and I've got some of those listed here. We see discrete trial training, early intensive behavioral intervention, pivotal response training, verbal behavioral interventions. All of those are types of ABA therapy. And although I'm not going to get into what each one of those entail, I just want you to know that all of these in some way try to promote learning of the individual so that we can reinforce positive behaviors and behaviors that benefit the individual in the long run, while at the same time decreasing, replacing, or eliminating behaviors that may block learning or may cause problems with some part of daily life. So you will If you deal with patients with autism spectrum disorder, chances are you will come into contact with some type of ABA therapy. I just want you to also know that there are schools of thought out there that this type of therapy might be or could potentially be a little outdated, and maybe a little aggressive for some patients who've been diagnosed. Some other types of interventions that we may see non-pharmacologically with autism spectrum disorder would include things that kind of fall under the umbrella of relationship development interventions. Okay, and so what does that really mean? One example of that is floor time. So what is floor time? Floor time is actually when a trained professional, when someone who has went through training for this actually gets down, let's say in the floor with somebody, and they start to meet the patient. They meet the individual where they are. Instead of trying to get the patient with autism spectrum disorder to adapt to other groups, other social circles, other types of neurotypical behavior patterns. In floor time, we try to get down in the floor with the child, and we try to meet the child where he or she is at. And so we really have an opportunity to bring out the uniqueness of each individual, and we're able to really help the child from their perspective make the most of their coping strategies, of their behavior patterns. And again, we're really not looking at the neurotypicality of the standard brain, but we're really helping the person enhance the uniqueness of their being. So you will see floor time used as a non-pharmacological agent sometimes. There's also this thing called TEACH. It stands for Treatment and Education of Autistic and Related Communication in Handicapped Children. This is basically an educational program. It's a structured program where we really think about the fact that a lot of patients with autism spectrum disorder learn visually. And so the classroom is set up to be predominantly a visual classroom. It's very structured. There's certain areas of the classroom that are set up for certain activities. And it really just helps the individual learn and really maximize their learning in a way that other people may not process information. You may also see occupational therapy. You may also see speech therapy, and you may also see sensory integration therapy used with people who struggle with or who are diagnosed with autism spectrum disorder. So you may be asking your question, why would occupational therapy be something that we see used with autism spectrum disorder? Well, occupational therapy may help the individual master certain ADL activities. It may help with balance, coordination, that sort of thing. Speech therapy may help with language delays or delays with just speech in general. And then sensory integration therapy, I think, is really important as well, because remember, early on in the presentation, we talked about that hyper reactivity to some of those sensory domains. Oftentimes, people who are diagnosed with autism spectrum disorder, they have a very intense intolerance of a lot of sounds, a lot of sensory stimulation that's coming at them from different perspectives at the same time. Well, that's really kind of distressing to some individuals. And so going through sensory integration therapy helps us to kind of intertwine, and it helps us to balance, mix, and more effectively process information that's coming from just more than one source. So you may see patients with autism in any number of these non-pharmacological programs. When we think about caregivers, when we think about the family, I think it's important for us to think about the lived experience of family members and caregivers. Here's some of the things that I've heard some of parents and caregivers tell me over the years about their child. You know, one person told me, "I'm only as happy as my least happy child." And I'm always afraid that my child is not happy. I'm always afraid that someone is going to say something to my child that is going to make them feel like they're less than what they really are. And so there's a constant worry in that parent's mind. And so you're only as happy as your least happy child. That's a big, significant stressor for some people, for some parents and caregivers who really worry about their loved one. I've heard other parents and caregivers tell me that they're stretched beyond their limits. They don't know what to do. They don't know where to go. Maybe they live in a geographical region that doesn't have a lot of resources. Also, I've heard people say this: I worry about what will happen to my child when I can no longer take care of them as I age. As things happen to me, and I begin to realize more and more that I won't always be around, who's going to be there to help my child? That's a huge stressor. That's a huge worry that a lot of parents and caregivers experience. Sometimes family members tell me they have trouble leaving the house because they worry about their child when they're gone. They worry that something's going to happen, something will um, happen during the course of the day that their child will not be able to handle. And so they really have a lot of difficulty leaving the house because of that. And you can kind of imagine the impact that that would have when the parent is the breadwinner, when they have a job to hold down, when they're forced to go out and spend the day somewhere else, not with their child. Sometimes there's separation anxiety there and a lot of worry. So it's really important for us, I think, to remember the lived experience of these family members, of these caregivers, because even though we're treating the patient with autism spectrum disorder, we're really also treating the family, aren't we? So always remember to check in with the family, help the family get the resources that they need so that they can effectively manage and cope with some of this stuff that they're faced with. Some of the other worries that I see families and caregivers talk about is the permanency of the condition. You know, these symptoms are lifelong usually. We can learn to adapt. We can increase our coping. We can enhance our resiliency, but we're probably always going to have autism spectrum disorder. And that's not necessarily a negative thing because we just look at things differently, but still it's a worry sometimes to parents and caregivers. And we need to help them understand that fact that even though their child doesn't think about things the way other people do, they don't process information the way that other people do, that doesn't mean that they can't live a good life. And so it's that uniqueness that we need to bring out and emphasize in our dealings with parents and caregivers. We need to talk about stability of the future. Parents and caregivers worry about that. They worry that their child will not be accepted by society and even some family members. And then also, there are patients out there who have been diagnosed with autism that really just don't have a lot of support in the way of family and caregivers. And so that's a worry as well. So there's all kinds of worries that the family experiences, that the family goes through. And I can't emphasize enough the fact that we need to include the family in the treatment plan as we go forth and we implement intervention. And so you can kind of see by just some of the examples of the different types of lived experiences that family members go through, you can kind of see the types of stress that caregivers and family members experience. It's psychological stress, it's physical stress, it's social stress, it's also financial stress. Sometimes family members have to decide whether or not to go to work on a certain day because of what's going on with their child. Maybe their life circumstances have gotten to a point to where they can no longer work full time outside the home, or maybe they're having to travel long distances in order to get the treatment that the patient needs. And so there's also those financial worries and financial stress that are added on top of everything else. Examples of some of those would be multiple appointments. Remember, most of the time, autism spectrum disorder is not a standalone thing. It has a high level of comorbid conditions associated with it. And so what does that mean for the family? What does that mean for the caregivers? Sometimes it means multiple appointments. We have to try to manage multiple appointments, and how are we going to get to one place or another place and still hold down a job or take care of the other responsibilities that we might have. It means advocating for educational needs with the school system. That's another thing as psychiatric providers we spend a lot of time on, is educating parents and caregivers about the educational rights, the educational resources that are available to them. Helping the child avoid sensory overload, trying to prevent some of that, is a huge stressor sometimes. Even something like going to the grocery store, taking a trip to Walmart, or maybe it's an outing to an amusement park or even a movie theater sometimes. Sometimes that can be very stressful for a child who has autism because of the hypo and the hyperreactivity to the sensory stimuli that they experience. Chronic sleep issues. Parents and caregivers report that they don't sleep well. That adds, because remember, if we don't sleep, everything else is worse. And then also, like we've already said, trying to juggle multiple obligations and also manage money and work around financial concerns. Those are all examples of some real stressors that families and caregivers experience. So what can we do about this? The first thing we have to do is we need to assess for caregiver stress. And so when you're in session with this patient, when you have the patient come in for an appointment, yes, we're focused on the patient, but also we need to focus on the family. Just asking the family member, how are you doing? Sometimes that goes a long way and is more therapeutic than what you would realize. Sometimes the family members feel like they're all alone, and just really asking, how are you doing, and showing some of that sincere attention and concern is very therapeutic sometimes to family members. So always check in with the family, see how they're doing. It's also important for us to highlight the fact that there's no single way to cope with this stress, just as there's no single presentation of autism spectrum disorder the same. There's no single way to cope with stress with the family and caregivers. We can help facilitate ways to help them cope with stress, but it's highly individualized. Not one thing is going to work for everybody. We need to educate the caregivers and the family about resources, and sometimes just being the sounding board. Sometimes it's not as much what we say and what we do as how we say it and how we do it. And sometimes family members just need someone to talk to. They need someone to vent their frustrations to. Sometimes that's very therapeutic. And then also give them the report that they need. Talk about simple changes in life. And also having a discussion sometimes with caregivers when they start to experience some of those what if worries. Sometimes those what if worries tend to be catastrophizing what if worries, and we start to imagine worst case scenarios. We can help patients, and we can help family members, we can help caregivers to really kind of reframe that and put that into more of a realistic frame. And also use your village. It takes a village, use your village. Let's maximize the resources that we have. And also sometimes families and caregivers, they just need some professional help themselves. There's no shame in that. And I've had many of a discussion with family members about this very topic. Sometimes you just need someone for you too, so that you can work on you in order to be able to be what you need to be for the patient. So in summary, when we're talking about caregivers, we're talking about family members, just remember to emphasize with these people, with these patients, with these individuals, to take care of someone else, you must first take care of you. That's a very important thing for us to emphasize with all of the patients that we see. And that concludes this general presentation of autism spectrum disorder. And here are my references. For some reason, I've got a couple things in the chat, but I'm not able to access the chat. Can someone see the chat for me?
Hi, this is Dr. Phillips. I'll go ahead and read the chat for you. It looks like we've got a couple of questions.
Okay.
Many compliments, wonderful presentation. Erica says, do you say who can diagnose autism? I may have missed that.
Very good question. Very good question. So typically what I see is the patient will go for psychological testing. And that's with a trained psychologist, and they will look at this testing, they look at those screening tools, and it really is a very in-depth analysis of the global picture, the global clinical picture of the patient. And so the diagnosis is sometimes a little more complex to make, just because there's so many different overlapping types of characteristics that we see. Um, Typically what we see is the diagnosis is made from neuropsych testing. But like I said, we have to look at the DSM-5 criteria. We also have to use good clinical judgment. And like I tell my students, at the end of the day, screening tools are a great resource, but they're no substitute for clinical judgment. Does that help?
That was great, Dr. Scalf. We have one more question. This question is posed by Tanya, and she states, as a parent, NP, and friend, this rings so true. Appreciate the honest discussion of criteria of ABA. Many autistic adults that I connect with feel that this is detrimental in that it decreases their ability to say no or their volition.
That's so true. And that's one of the things that I think as a society that we really need to spend more time thinking about. Not everyone has a neurotypical brain, and that's okay. And it's all about helping individuals to reach their maximum potential. And if we're going to be able to reach our maximum potential, we first have to feel good about ourselves. We have to feel that it's okay, that we look at things differently, that we process information differently. That's all right. And I think we have to come to a place in society where we really give that a second thought. And so, although ABA therapy has been around for a long time and it has a lot of efficacy backed up in the literature, um, there's some individuals that feel like that ABA therapy kind of forces them to look at things from the standpoint of a neurotypical brain. And sometimes that causes issues.
Looks like we have one more question, and this is posed by Dr. Barnes. She states, I'm sorry, this is posed by Ashley. Have you seen a hyper focus on an individual rather than an object, a child being drawn to another person like one drawn to an object, such as cars or toys?
That's an excellent question. And I have seen that to be true in the sense that sometimes the child has severe separation anxiety. Remember, there's an insistence on sameness with patients and individuals who have autism spectrum disorder. Little changes in the environment equal big challenges sometimes. And if a patient has really become accustomed to a certain routine, maybe that certain routine is associated with a certain person. And they see that person as a area of safety for them. And if that person was to maybe go away out of that environment, I've seen that cause a lot of pathological anxiety. The problem is sometimes the patient cannot tell us that they're feeling anxious. And so we have to kind of read between the lines and interpret the symptoms and the characteristics that we see clinically. Sometimes that anxiety will come across as irritability. Sometimes it will come across as physical aggression, like head banging, self-biting, biting others. That's more at the severe end of the spectrum, but sometimes that behavior is secondary to some anxiety that the person just cannot verbalize to us. And so we always have to keep an open mind when we think about and we look at these behavior patterns, because at the end of the day, all behavior has meaning. It's just we're tasked with the responsibility to try our best to interpret what the meaning of this behavior is for this person. And so a long way around to answering your question, I guess, is I've seen the hyper focus on individuals, but mostly it's been within the context of that individual serves as a sense of security for the patient. And when that's taken away, it causes a lot of distress.
We have one question from Sylvie, and she's asking if you can please speak to the broken mirror theory of autism.
Broken mirror theory. I would have to say that I'm probably not up to breast with that as I could be in order to have a discussion about it. But if you will email me that question, I will research it and I will get you the answer back to you. Well, if there are no other questions, again, I appreciate each and every one of you for coming out tonight and joining me with this discussion. Again, this was a general discussion, kind of an introductory discussion. There's so much information, so much stuff to know related to autism spectrum disorder. And like I've said time and again in this presentation, we've come a long way, but we have a long way to go. There's lots that we know, there's lots that we don't know. But at the end of the day, the thing that I believe is the most important thing that we can communicate to a person with autism spectrum disorder is that they are unique, they're different, and that's okay.
Dr. Scalf, I do see one additional question. I'm sorry. It is, this person is curious if you can offer guidance about the popularization of adult self-diagnosis.
I can talk a little about that. And so I think there's different schools of thought with that, and I've heard different types of things related to that. So I will kind of give you my perspective on what I have been kind of exposed to in my experience with that. I think with the self-diagnosis part of anything, I think that we're really good sometimes in identifying things that we struggle with. I think that we're really good sometimes putting the dots together and really recognizing the fact that I'm struggling with this or that, or I have this or that. It's really important, I think, for us to also look at the resources and the references and the source of the information that we're gathering things from. And also, I think that we need to collaborate with someone that is trained in this area and that can really help us to effectively rule out self-diagnosis, because we all know in this day and time, technology is readily available. We can look at Dr. Google, we can look things up, but not everything that we read is credible. So it's really important, I think, for us to be informed as a population of people. I want my patients to be informed. I want the parents and caregivers to be informed, but at the same time, I want to point them in the direction of credible information and good avenues of learning. And so I think that we know when things are wrong in our life, when we feel like that we have opportunities for improvement in certain areas of our life, and we feel distress when we're kind of faced with certain situations, we can pick up on that distress. It's just really important for us, I think, to also be objective and have an objective professional in the mix of that, because sometimes we can be too close to a situation to really become objective like we need to be. Having said that, one of the things I say all of the time as well to my patients is you're the specialist when it comes to you, because you know you better than anyone else in this entire world. So I would say that it's good to be educated, and it's good to know and have insight into things and keep abreast with the knowledge, but also I think it's good to have that objective lens with a healthcare professional so that we can really truly hone in on what the problem is. We see these symptoms that we see, these characteristics of autism spectrum disorder, but at the end of the day, those symptoms can also be part of so many different disorders and diagnoses that we deal with. There's so much overlap in symptomatology. And I think sometimes that's where we really need to proceed with some extra caution. If you think about questions after you log off of here, feel free to email me at any time. I'm more than happy to have a discussion with you. And I'm more than happy to entertain questions. And if I'm not for sure what the answer is, I will work to find it out for you. And so if there's nothing else, I appreciate everyone for coming out and thank you for being part of this activity.